Hello everybody. Okay, now this week we're going to be focusing on bones and the musculoskeletal system, osteo everything. So I'm going to do chapters 41, 42, and 43 in your Lippincott book. I will expect that you know Chapter 40. Chapter 40 is all about how to do a proper musculoskeletal bone assessment. So if you're not familiar with that, if you missed that from anatomy, physiology, or physical assessment, then go back and review that. So I'm just going to assume that you'll know that. Okay, starting in Chapter 41, let's start. A couple things in the glossary I want to point out. You do need to be familiar with abduction versus adduction. Those are words that are used quite a bit in the medical literature, and it's important for you to understand what those mean. Abduction is going away from your body. Adduction is coming in. And the way that you can remember that is add, like you're adding something to yourself. So keep those things in mind. Fracture, I'll tell you about external fixator, and a trapeze. A trapeze is important. It's like, I'm sure you've seen in a hospital bed where they have all that apparatus, the metal apparatus up over the bed, and then there's like this trapeze thing that patients can hold on to. That's really useful for your patients who have fractures or they're in traction or something. So if you're not familiar with what that is, Google it. Google image what an orthopedic trapeze looks like. Okay, so let's talk about patients who are in casts, splints, or braces. Obviously, a cast is necessary if your patient has some kind of a fracture. Splints or braces are used for soft tissue injuries, or when a patient is out of a cast, if they need a little bit of reinforcement for a while, they can be put into a splint or a brace. It is important for you to know the different kinds of casts, like the short arm cast, a long arm cast, a hip spica cast. Hip spica is around the whole trunk and then usually down one or both legs. Those have a lot of different nursing elements to them because the patient tends to get iliases. It's hard to assess their abdominal sounds because the cast is surrounding their entire abdomen. So with each of them, with each of the kinds of casts, there's some nursing implications that go with it. Most of the casts that they put on a fracture now are fiberglass casts. And so what will happen is the patient will come in with a fracture. We'll go over the different kinds of fractures in a little bit. And then they put like a cotton sleeve over the skin, and then they wrap the fiberglass on top of that. The fiberglass is often, it comes in a sealed package, and then it is either air activated or water activated. So sometimes if you just open up the package, the airtight package, then you wrap it on the fractured arm or wherever, and then that'll start hardening, or you dip it in water, get it wet, and then wrap it, and then that starts hardening. Those are fiberglass casts. They're lighter weight, but not quite as durable as the plaster casts. However, almost nobody uses plaster casts anymore. The plaster casts are the kind you could see where people used to write on them all the time. They are heavier. You can't get them wet at all. They do have some casts now that are waterproof, where the cotton sleeve is actually like a gel type stuff, so that and that's really good for like swimmers who have broken their leg or something like that. They still need to swim, but because most casts you can't get wet, which is a problem, because if you have a cast on an arm, let's say there's like that cotton sleeve, and then there's a fiberglass cast over that. If that gets wet down in there, now you have to start worrying about skin breakdown, infection can get in there. So you have to teach your patient either to take a bath and keep the immobilized limb out of the bathtub, or wrap it with plastic in the shower. And it's cumbersome and problematic. Most fractures need to have a cast on for about 6 to 8 weeks to properly heal. Because during that amount of time is what it takes for the bone to reform. Right after the fracture, like a hematoma will occur, and then the osteoformation begins, and then it's about 6 or 8 weeks later that the bone is fused well enough to withstand mild pressure. Once you take the cast off of somebody, which is usually 6 to 8 weeks afterwards, they can't resume like physical contact right away because that bone is still healing. The bone, it takes almost a year for it to become as strong as pre-fracture, but people can resume normal activities, prior to a year, but the bone is, it's going to take about a year for that bone to completely heal. So then the removal of the cast, when the patient is ready to have their cast removed, there is it's a device. It looks like a circular saw, and it sounds like a circular saw. So one thing that you have to do as a nurse is prepare your patient for what they're about to experience, because when the physician comes in, or the orthopedic physician comes in to take the cast off, and they fire up this drill thing, if you have not prepared your patient, especially if it's a young child, and all of a sudden this drill's like zzz, and then they put it on the arm, you need to reassure the patient that the cast, that drill thing won't hit the skin. It's not going to cut the skin. There's mechanisms on it, and it just goes down really, really shallow just to cut through the depth of the cast. So when it's ready to come off, they put the drill on, zip it, and they usually drill down each half and then just take it off like that. That's also called bivalving a cast. So sometimes when your patient has a cast on, there are times when you need to relieve pressure, and like if you suspect that compartment syndrome is starting, and I'm going to tell you what compartment syndrome is in a minute. But if the physician decides that underneath that cast is too much pressure, too much swelling, and they need to bivalve, B-I-V-A-L-V-E, the cast, they'll cut down this side and this side. They'll leave the cast in place and then wrap the whole thing in an ACE bandage. So that has a little bit of elasticity to it, but the stability of the cast stays in place. So you as a nurse, what you do is, one, prepare the patient that we're cutting the cast. It's not going to cut your skin, but we're going to leave the cast on, and now we're going to wrap it with an ACE wrap. And but the patient needs to be instructed that they can't take that off. It's not like a brace or a splint that you can take off. They still need to keep it immobilized in the cast, because casts immobilize fractures much better than splints and braces. Okay, so now let's talk a little bit about splints and braces. A splint, sometimes if there is just a real simple fracture, a stress fracture, something that's not a full-fledged fracture, sometimes they can just put it in a splint while it's healing. Or like tendon injuries or sprains sometimes are put in a splint, and there's a couple different kinds of splints, like sugar tong splints. Sometimes the splint is just like half of the limb. So like let's say let's say there's a sprained wrist or something. The orthopedic surgeon or the sports medicine doc may decide to just put that hand in a splint. And that goes kind of like underneath the bone, or some of them go on top of the bone, or depending on what's injured. And then it's often wrapped with Velcro and things and it holds it in place, but not quite to the degree that a cast would. And then the other kind is a brace, and a brace is usually goes all the way around the injured limb, usually with Velcros. Some of them you can get over the counter, like CVS, some of the pharmacies, and that's helpful for patients that have, especially like the repetitive injuries, like carpal tunnel disorders and things like that. They can wear a brace to kind of support those tendons and ligaments. So there's a difference between a splint and a brace. braces tend to be more custom fitted. You'll see a lot of the sports players walking around with knee braces, especially following like ACL tears with, followed by surgery. They'll have a big knee brace on. So kind of look through there and make sure that you know the difference between a cast, a splint, and a brace. I'm sure you know that, but you need to know it even more because you're a nurse, more than like the general public. Okay. The next thing, that the nursing implications of patients who are in either casts, splints, or braces, is you have to know what's called the 5 Ps of distal extremities following an injury or a fracture. Let me go over again what I mean by medial and distal and proximal. You need to understand what those words mean. Each bone resets from proximal, medial, and distal, and it's all within proximity to the trunk or to the core. So for example, if I'm talking about my humerus bone, this is my proximal humerus, this is medial because it's in the middle, and this is my distal humerus because it's the furthest away from my core. But then when I get down to my radius and ulnus, now I'm going to start over. Now up here is my proximal radius and ulnus, medial radial ulnus, and then distal radial ulnus. And then you do the same thing with the phalanges. Each bone starts over. So that's how you, like, that's just anatomically, you need to understand those words. So when you have an injury to a bone or a tendon and ligament, it is very important that you get really thorough assessments, neurovascular. By neurovascular, I'm meaning arterial venous circulation and nerve. So that's your feelings and your sensations. So your neurovascular assessments, distal to the injury, is really important. And you're looking for the 5 Ps, which you can see on the bottom of page 1105. If any of these 5 things show up, you have some neurovascular compromise that needs to be addressed and dealt with as a nurse. So you're looking for pain, and this is pain just that's unrelieved with Motrin or some pain medications, because at the point of injury, that hurts. A broken bone hurts a lot. Sprains and tears, they hurt, but they should be relieved with some pain medication. Unrelenting pain is not a good thing. Pallor, meaning cool, pale skin, not good. Now I'm compromised my arteries. I'm not getting good blood supply. Pulselessness is obviously not good. So if you all of a sudden can't feel pulses distal to wherever the injury is, that's not good. Paresthesias, meaning numbness and tingling, or paralysis, inability to move. So if I break, my radius, I should be able to move my fingers like this. If I can't, I have nerve damage. So that's one way you can tell if there's nerve involvement, is they won't be able to move the limb if they have a fracture, but they should be able to move the fingers distal to that. And once the broken bone or the injured extremity, tendon, ligament is immobilized, you want the person to still be able to move their fingers, contract their hand, because you want the blood supply to go through there. Bone doesn't have a lot of blood supply in it, neither do the tendons or ligaments. And so you want to keep blood flowing through there, because you want to prevent some of the very common complications that can occur following fractures. But if somebody was moving their fingers, or, in the case of, like a broken hip or something, in a broken hip, they're not going to be able to move their knees, but they should be able to move their toes. If they can't, then you might have like tendon ligament problems or something like that you need to address. Okay. Then follow the other, this is basic 101. After the injury occurs, either the bone or the tendon and ligament, it's a good idea to do the RICE, rest, ice, compress, elevate, at least for the first 48, 72 hours. So your R is your rest. In the first 2 or 3 days following the injury, this is not the time we're going to start a range of motion. Just have the person chill out, rest, because that's also the time when your swelling and edema is going to be the worst. So we're just going to rest it. We're going to put ice on it to try to keep the inflammation down. And you can ice right over a cast because it will, I mean, it's not as effective as over like an ACE wrap or something, but it'll still get cool. So you still want to ice it. You want to compress it. You want to keep the ACE wrap on there, compression bandages on there, keep the splint tight enough, but not so tight that it causes compression, and elevate. You want to keep it elevated above the level of the heart until compression or compartment syndrome happens. Then you don't elevate, but in the initial phases of an injury, rest, ice, compress, elevate. Okay, so that's sort of your basic how do you treat a musculoskeletal injury. Now, some of the problems that you have to watch for, the biggest one is compartment syndrome. Your body is made up of about 40 some odd, 46, 40, 45, 46 compartments, most of which are in the muscles. And if you look on the bottom of page 1107, you can see what I'm talking about. In figure A at the bottom, that is a cross section of the normal leg muscle, and you can see those little compartments in there. There's a bunch of compartments inside that muscle. Sometimes what happens when a bone has been injured or a tendon and ligament has been torn is something called compartment syndrome, where the swelling starts getting so significant, but it doesn't have anywhere to go. And it could either be restricted because of a cast put on. It can be restricted because the skin is tight and it's not able to stretch as to accommodate that edema, so it'll start compressing back in on itself. And that's called compartment syndrome. And the problem there is that it then starts compressing those arteries and those nerves, like I told you about. So that's why you do your 5P assessment, is because you'll start getting pulselessness, pallor, coolness, pain, paresthesias, numbness, and tingling. If those things start showing up, your patient may be developing compartment syndrome, and you need to notify somebody right away, because that can become a medical emergency. So the causes of compartment syndrome really can be anything. Trauma patients are at risk for it. Crush injuries, especially because there's a lot of crushing inside, but the skin sometimes is still intact. Those can lead to compartment syndrome. Casts and tight bandages that are too restrictive can cause it. Surgeries, you know, that kind of thing. So if you think that your patient, because the problem is, especially in bone fractures, you want to get it immobilized as soon as possible. So they will often, if a bone is fractured out, in the public, they will come in to the emergency room and get that bone casted right away, especially if they don't need surgery. And so they'll put the cast on it. So that way it does two things. It helps stop the pain, because an unimmobilized bone that's fractured is very painful, because the bone is rubbing on each other. It's super painful. So as soon as you get it immobilized, the pain starts getting better. And also, the sooner that you can immobilize it, the less likely you are to have more complications from that fracture. So you do want to immobilize it quickly, but then you need to assess distally for those 5 Ps that I was telling you about. And if it doesn't, that's when you may have to bivalve that cast, wrap it in an ACE wrap, and then have the patient come back in 2 to 3 days later when the swelling has gone down to recast it with a better fitting cast on. So that's one way to deal with compartment syndrome. If the compartment syndrome is following like surgery or something like that, sometimes they have to do a fasciotomy, where they go in and they actually cut the fascia to open up pressure to relieve the pressure from compartment syndrome. So sometimes if it's so significant, it's a surgical procedure called a fasciotomy, similar to an eschar-otomy like we talked about with our burn patients. It's similar to that. It's a surgical procedure to remove pressure. Okay, the other thing I wanted to talk about was disuse syndrome, because what happens when somebody is immobilized because of a fracture or an injury is that muscles start atrophying very quickly. And so one of the complications and the tricky parts about taking care of our patients who have orthopedic injuries is to try to maintain as much muscle mass as possible. You want to avoid muscle atrophy, so you want to use things like if they have a trapeze above their bed, you know, they can use that to help turn themselves. They can you know, move their hands, do some range of motion. After this is, you know, 3, 4, 5 days out, once they're a little bit more stabilized. So you do want them, it's a little tricky because you want to maintain immobility and alignment, but you want to maintain movement as much as possible too, to keep the muscles for least amount of atrophy as possible. Another problem, another serious complication of impaired circulation, especially in the arm, is something called the Volkmann's contracture. This is a very specific kind of contracture that is specific, like to compartment syndrome, and it is caused by obstructed arterial blood flow. So one thing that you can do is when if your patient has an arm fracture and they all of a sudden have obstructed blood flow because of compartment syndrome, they'll start getting finger contractures like this. That is called Volkmann's contracture, indication that you might have compartment syndrome going on, and that needs to be assessed immediately. You can find more information out about Volkmann's fracture on page 1109 of your textbook. What else do I want to tell you about that? Okay, so another way is you want to make sure that distal to the injury, the fracture, the person can move either their fingers or their toes, because if they have that inability to do that, you've got nerve damage, because it's your brain tells your fingers to move. It has to send a signal down through those nerves in your fingers and your toes. If they can't, you've got a nerve problem. And that you need to notify the physician right away. Oh, yeah, you know what? So read that, see the quality and safety nursing alert on page 1109. That tells you a little bit about that, what I was talking about nerve compression. The other thing, that if your patient has such a significant fracture, it's not, and we're gonna talk about the different kinds of fractures. I'm not sure if it's in this chapter. It might be in another chapter. I think it's another chapter that tells you the different kinds of fractures. Some fractures are so significant that a cast is not enough. Like if the bone has been shattered, or, you know, convoluted in some way, sometimes the patient has to go for surgery. Sometimes they can fix the bone in surgery, and that's where they put plates and screws on that bone. Sometimes they have to have an external fixator, which you can see in figure 41.3 on the bottom of page 1110. If your patient has a broken bone and then they have to go for surgery, that's called an open reduction internal fixation, ORIF. And ORIF is a surgical procedure that is open, meaning they cut the skin, reduction, and I think I've told you this before, but anytime you hear the word reduction, especially in relationship to surgeries, that means they're either taking something out and putting the two pieces together, like a reanastomosis, or they are, like in this case, a reduction. Like let's say that you have a broken bone, the bone looks like this, and if you open the skin, that's the open. Reduction, and reduction is where you realign it like that. That's called a reduction. Internal, meaning inside, not like a cast is external, but internal. Now they're inside, they're fixing that bone. Fixation, meaning they've got something on there to either a plate or screws or something like that. This guy in figure 41.3, he probably had, I don't know for sure if he had an open reduction internal fixation or just the external fixator put on. They would be able to determine that on x-ray if they have to actually take him to surgery, or if they can put an external device on and fix it that way. And they will leave the external fixator on for 6 to 8 weeks. This one looks a little more scary, but it accomplishes the same thing as a cast, just for more complicated breaks. The nursing thing with an external fixator is now you've got these screws going through the skin, so you need to teach your patient how to take care of the screws going into the skin. And usually just wash with warm soapy water 2, 3, 4 times a day. We don't use hydrogen peroxide anymore. Studies have shown that that's not effective and sometimes even worse. You need to teach your patient what to watch for signs and symptoms of skin infection, when to call the physician when they're starting to get a fever, general malaise, that kind of stuff. It could be that they're getting an infection. The other thing that we have to watch for in our patients, especially that have external fixators or an internal fixation device, or in any type of open compound fracture where that bone is now exposed to the elements, you need to watch for osteomyelitis, which is an infection of the bone. That's a very serious infection and complication from some of these injuries, and we'll talk a little bit more about that. The whole goal with all of these is you want to avoid the osteomyelitis. Osteomyelitis is hard to treat because bones don't have a lot of blood supply to them, so it's hard to get antibiotics and agents that will fight the infection where it needs to be because there's not a lot of blood supply in there. Okay, so then sometimes you might have to put your patient in traction. Traction used to be more common than it is now, but the thing that you need to watch for, a lot of hospitals still do traction. You'll have an ortho unit and all the patients in there will be in traction. Traction is used to, so let's say you have a break like this, and you can't get to surgery right away, or it's so bad that they want the swelling to go down. They will put a patient in traction, meaning they will they'll put usually pins in here, or sometimes they will put an external boot on and wrap it with Velcro, and then they'll add weights to it. They'll drop the weights off the end of the bed and hang them, so because you don't want the weights hitting the floor, you'll hang it, and what that does is it puts weight on this bone and it stretches it out and does like a manual reduction of the bone. It also helps prevent muscle spasms, because sometimes following a break those muscles can spasm a lot, so you want to stretch out those fibers to help the muscle spasming improve. Things as a nurse is that it's hard when somebody's in traction because you have to maintain traction, because if you release traction for even the smallest amount of time, the bone can get malaligned again, and then you have to call the surgeon or the orthopedist to come fix that. So usually the problem is, you know how your patients slide down in bed all the time. Well, now you've added 5 or 10 pounds of weight, and these patients are constantly sliding down to the end of the bed. Well, you can't let those weights hit the floor, but you need to slide your patient back up in bed. So what usually you do, if they have a trapeze, you can have the patient help pull themselves up. But the other thing is, if you've got 5-pound weight down here, you don't want the patient coming up this way without supporting those weights, because now you're going to pull the bone out this way. So typically it's easier if you have 2 nurses, one helping to support those weights and the other one's helping to pull the patient up, and the patient can pull himself. Sometimes this is a 3-nurse job. Also, when they're turning side to side, because another big problem with your patients who are in traction is they're just laying in bed, and now decubitus ulcers are a big deal, because you can't have somebody turning from side to side and getting themselves out of alignment. So you can do things like put pillows under one side and then take that pillow out after 2 hours and put it up on the other side of their, just to kind of shift the weight a little bit. If they have one good leg, they can use that leg to raise their buttocks off the bed, and you can do a good back and buttock assessment and have them do that every couple hours, as long as they're maintaining traction. So there's a couple pictures here. 41.6 is an example of a patient in traction. 41.5 is a patient who's in Buck's traction. That's a really common one that they do for tib-fib fractures. So read over, like on page 1112, there's principles of effective traction, but just so that you're familiar with what traction is and why it's done. It does require a little bit of nursing skill because you got to make sure that the skin isn't breaking down. You got to make sure they're not getting an ileus. You got to figure out ways to get bedpans under them when they have to eliminate their bowels or bladder. You have to help them eat. So there's a lot that goes on in a patient who has traction. Okay. What else do I want to tell you? Oh, yeah. Do look through, I guess there's quite a bit of information here on nursing interventions about traction, maintaining position, skin breakdown. The other problems when somebody's in traction is they are at high risk for developing DVTs because they're laying flat, especially that one leg. That one leg is completely immobile and not moving, so you need to be very careful that they're not developing DVTs. Deep vein thrombosis. So you're going to watch for things like that. If that calf is starting to swell up, if the calf is warm to the touch, the patient could be developing a DVT. So you want to do preventative things. You want to things like SCDs, sequential compression devices on the legs to keep the blood going, if you can, depending on if they got all those external fixators. Obviously you can't. TED hose, if they can't have any of those, heparin, Coumadin, aspirin, anything to prevent that, and then watch for signs that that the DVT is occurring. You have to, if they do have a DVT, now you got to worry about if something clots off there, it could cause a PE. So you always assess their airway status. The femur, broken femurs also have something, they're at higher risk for something called a fat embolism, and they're not entirely sure why it's the femurs, it's the large bones. That once those are fractured, sometimes they can throw little fat embolisms into the arterial system, and that can cause a PE, and they can get these little red petechiae spots on their chest. That's classic fat embolism. So you have to watch for that in your patient who has had fractures, especially in the leg bones. Okay, so finish reading through that. Let's see. Joint replacement. This is the arthroplasties are really common. Patients, especially like hip replacement and knee replacements, are fairly common surgical procedures, and those are done for people who have really bad knees or have degenerative hips. The hip replacement is actually easier procedure than knee replacement. You would think it's the other way around, but it's not. Knee replacement is horrific. Google that sometime. Look up on YouTube knee replacement surgery. Oh my word, it's brutal. They cut they cut like at the bottom of the femur, and then the poor leg is just kind of hanging there, and they ram this stuff up. The orthopedic surgeon is just whacking this big rod up into the femur with, it looks like hardware tools, and then they put the base of it down into the tibia and secure it, and then put the whole new knee in there. It's really a painful surgery, but patients have really good outcomes, because usually you don't do a knee or hip replacement until somebody's in pretty significant pain and there's significant degeneration of the joint. So immediately following surgery, once they have those surgeries done, they feel a lot better. Now, they do, especially with hip surgeries, they get them up walking right away. One thing that you have to be worried about with your patients who have had hip replacements is they can't bend over more than 90 degrees because they'll pop it out, especially in the early phases. So they have to use devices like they have all kinds of devices where they can tie their shoes without bending over. So you don't want them leaning over, bending their shoes. You don't want them leaning over, brushing their teeth. So they have to be taught to kind of, just lean a little bit so they don't pop that hip out. That's called a hip arthroplasty, and it's really common. There's a whole plan of care in here. So if you're in clinicals taking care of a patient who's had a hip replacement, there's your care plan right there. And like I said, they get them up walking very, very quickly, especially with hips. Not so much with knees. The knee replacements are much more painful. So, but they usually have therapy pretty quick following knee replacement surgery. Okay, and I guess that's about it for chapter 41. That's just sort of an overview. In the next couple chapters, in chapter 42 and 43, we're going to go into a little bit more about some of the musculoskeletal disorders and more about trauma in the next couple sections. So that'll be it for chapter 41, and then we'll do 42 and 43 next. Okay, see ya.